Hi, Belkin. How are you? Okay, she's connected. I'm not too fast. Well, the live stream is going to start and everything's okay. Yes, let's get in silence. Hi, Belkin. How are you?
Hi, I'm tired.
Yes, me too. Let's go ahead. Always is nice to see you.
Well,
Today we have a very important class, hardful to prepare, but it's ready for studying.
well, I have a lot of study.
Yes, me too. Me too. I have lots of readings and remembering vocabulary and writing facts, topics. So I'm running great.
It's hard teach, it's hard work. It's very difficult to make several things at the same time.
Yes, it takes more time than sometimes I expect.
Yeah.
But that's okay. I love teaching. I don't know why, but I like it. So
I guess it's not easy.
let's be patient and no, it's not. But it has many things that can be considered okay, I think. I just received your case report.
Yeah.
Well, I didn't read it yet, but I'm gonna do it while finishing. So let me send you the key I was showing you. Yes, my computer is running crazy, and today it made lots of mistakes earlier. I hope there's no problem now. Who's coming? Okay. 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 Okay, Belkin, I sent you the guideline for the case report. Did you receive it? Okay. Hi, Ariana, how are you?
Hi.
Hi, everything's okay?
Yeah, everything okay.
Okay, perfect.
What about you?
Well, so tired, but everything's going fine, I think.
I can only imagine.
Okay. Let's wait 2 minutes more, then we can start, okay? So
Okay.
it's a long session, long class that I was preparing. Okay, let me open video. Okay, give me a minute. I'm gonna open the presentation. Hi, Harold, Fabiola, Mario, Ruth. I'm checking. Agar, Johan. Well, everybody's coming now. That's great. Fine. A little tired, but everything's okay, I think. Okay, let's start because, well, it's a long session. We have too many topics to check. So I think that's the correct moment. Can you watch my screen? Is that okay?
Yes.
Yes.
Great. So today we are going to talk about many situations, many topics that I think are very important. And well, we have lots of vocabulary to start practicing again, and of course doing and reading and you know, having into our new terminology, medical terminology. Okay. Today we are going to talk about the nervous system, mental illness, blood in general view, and oncology, of course, general view of almost everything. Because there are topics too big, I mean, too huge to treat in not too much time. So, of course, I'm trying to do the best way this presentation in order to get everything understood. Okay. So let's go ahead. First of all, the nervous system. Of course, we know that it's the most important, and this is the topic that I consider is the biggest one in this session. We have, of course, this picture that is showing us how it's supposed to be in order to get functions. But we also know that these functions are theoretical. I mean, we have now research that support that any hemisphere can add activities from the other one, right to the left, left to right. That's also our anatomical review. We have this first picture, an anterior view showing how the brain is divided into the right and the left hemispheres. So it's clear with the brainstem too, okay, and the cerebellum. The neuron anatomy, of course, taking all the vocabulary that we must remember, the synapse, the axon, the Schwann cell, the myelin, how the neural impulse goes, the dendrite, the cell nucleus, and of course, the synapse, a perfect closer view of sight, I mean, checking all the structures we study. The presynaptic axon, microtubule, lots of mitochondria, neurofilaments, synaptic vesicles, vesicles releasing neurotransmitters, of course, and dendrites that are receiving the impulse. We have types of neurons and their functions. Of course, the ACE and the SAM, the ACE and the SAM. The references are helping us for understanding all these actions. The afferent neurons, connecting neurons, and efferent neurons. Anybody would like to read it? Maybe a volunteer. Hello.
I can read.
Yeah, yes, please go ahead.
Afferent neurons. Afferent means toward. Also known as sensory neurons, these neurons emerge from sensory organs and the skin to carry the impulses from the sensory organs toward the brain and spinal cord. Connecting neurons, also known as associative neurons, these neurons link afferent and efferent neurons. Efferent neurons. Efferent means away from, also known as motor neurons. These neurons carry impulses away from the brain and spinal cord and toward the muscles and glands.
Perfect. So we have vocabulary, for example, sensory organs. Oh, I'm sorry. It opens again. Sensory organs and associative neurons, motor neurons. That's important for us, okay? To remember and practicing, because it's the expressions we were talking yesterday in the workshop, the correct expressions for making a correct referral, for example. Then we have our nervous system, a general view with all of the anatomical references, okay? Brain, spinal cord, musculocutaneous nerve, radial nerve, median nerve, lumbar plexus, the ulnar nerve. Of course, we have it marked and showing the situations, okay? Saphenous nerve, sciatic nerve, sacral plexus, pudendal nerve. We all know these structures. And we have here a cross-section of the brain showing the meninges and the protective coverings. The cerebrospinal fluids is shown in purple, okay? We have this picture that is, of course, for remembering as anatomical structures. We have another one, another cross-section showing the major parts of the brain, okay? Of course, having the correct way of writing down and for practicing in there. And then we have this chart, the brain parts and their functions. Maybe someone would like to read it. Just the brain part. Function is for checking for practicing home, okay? A volunteer maybe? Okay, okay, Belkin, go ahead.
Brain part. The cerebrum, which is the largest and uppermost part of the brain, consisted of 4 lobes. The thalamus is located below the cerebrum. The hypothalamus is located below the thalamus. The cerebellum is located in the lower back of the cranium below the cerebrum. The brainstem is located in the base of the brain and forms the connection between the brain and spinal cord. It consisted of the midbrain, pons, and medulla oblongata.
Perfect. So I think it's a good review for having in mind that all the structures we are studying for from this point, okay? So go ahead. Now we have this another picture identifying the cranial nerves, okay, the numerals. We all know, well, all of us know how it's working on, and of course the function they serve. We have here, of course, vocabulary. For example, I don't know, the vagus, Erlandas, okay, sensory, we know it, the accessory, hypoglossal, facial nerve, the trigeminal sensory nerve, oculomotor, optic, olfactory. Well, we know about it. Don't forget how to write it and spell it, okay? About the peripheral nerves, we have the dermatome and the myotome. Okay, dermatomes and myotomes are an innervation good way of remembering and working, and of course, getting how to deduce which nerve could be healed, could be I'm sorry, could be injured. Okay. A dermatome refers to an area of skin innervated to the nerves from a single spinal root. A myotome refers to a group of muscles innervated by the nerves of a single spinal root. A dermatome, a region of the skin innervated by a single spinal nerve. And a myotome, a group of muscles innervated by a single spinal nerve. We can see the difference, right? Just a region, a group of muscles, okay? The dermatome, some consists of overlapping regions innervated by more than one spinal nerve. And myotome, some are innervated by more than one spinal nerve. A dermatome is responsible for the coordination of senses. A myotome responsible for the coordination and voluntary muscular movements, okay? So with this picture, we have the division, the innervation of them. More anatomical review of the peripheral nervous system. Both sides, both pictures for remembering all of them. And now the parasympathetic nerves and the sympathetic nerves, okay? Now we are with our chart, structures combining forms and functions of the nervous system. Maybe volunteer for reading. Could be, I don't know, Fabiola. Can you read it, please?
Of course.
Okay, go ahead.
Structures combining forms and functions of the nervous system. Major structures: brain, spinal cord, nerves, sensory organs and receptors, eyes, ears, nose, skin. Related combining forms: cerebro, encephalo, myelo, neur. Primary functions: coordinated all body activities by receiving and transmitting messages throughout the body. Transmits nerve impulses between the brain, arms and legs, and lower part of the body. Receive and transmit messages to and from all parts of the body. Receive external stimulation and transmit this stimuli to the sensory neurons.
Yeah, perfect. So I think it's clear, just for remembering. And now we have our prefixes and suffixes, okay? So just for practicing and having the idea for constructing the terminology and remembering all the structures we can write in a correct way. Let's talk about tendon reflexes as a general view, As the examination of the nervous system normally includes testing the deep tendon reflexes. For example, knee jerks with a tendon hammer, also known as a reflex hammer. We have 3 models of them, and just a picture for how to use it, okay? Johan, can you read this chart, please?
Yes, the reflexes may be absent, diminished, normal, or brisk. The plantar reflexes are also checked. The normal plantar response is downgoing movement, plantar flexion of the big toe. An upgoing toe or Babinski response is abnormal.
Perfect. So we have the description of plantar reflexes taking this scale, okay? Thank you, Johan. So we have this first chart, remembering how is the grade made on from 0 to 4+. Okay, for non-response absent, 1+, somewhat diminished, low, normal. 2 plus, average expected response or normal, that's the most common. 3 plus, brisker than average, slightly hyperreflexic. And 4 plus, very brisk, hyperactive with clonus. So this is just for remembering what we have to use the correct vocabulary for describing these findings, okay? Then we have more charts. The deep reflection, the deep tendon reflex, the muscle that is involved, the nerve supply, and the root supply. Remembering this chart, we can get, of course, a closer idea of which the lesion is originated and what we can do about it. Just as a general view, we're talking about reflexes. So we know there's a lot of material to do. Knowing the reflexes are evaluated, we remember how it works, we can go to the motor system. Maybe, Catherine, can you read this slide, please?
Yes, teacher, I'm here. The motor system. Examination of the motor system should include assessment of the following: muscle bulk.
Muscle bulk.
Okay, amount of the muscle tissue. Look for sign of wasting, muscle atrophy.
Thank you so much. So we have here the normal muscle, the bulk. This is the bulk, the body of the muscle, and the atrophied muscle. That, of course, it's smaller, losing all the capabilities it should have. Okay. The first part of the examination, don't forget it, the muscle bulk, and look the muscle bulk. Okay, okay. The muscle tone is the second one. The amount of tension in a muscle when it's relaxed. The tone can be increased, spasticity, or decreased, flaccidity. Okay, we can notice the difference, okay? It's a normal situation, position, of course, joven, it's spasticity, of course, and inactive flaccidity without the normal situation, height and everything. The muscle power, of course, the strength. I couldn't find a better picture, but I think that it's clear in the concept we are talking about. And the coordination, of course. Mario, can you read this slide, please?
Yes. Coordination is the ability to use several muscles at the same time to perform complex actions. For example, gait and a manner of walking reflexes.
Thank you so much. In these pictures, we are showing how this man is practicing coordination by hands and toes, hands and eyes and toes, of course, with several exercises and complex movements, for example, contralateral and ipsilateral. And of course, it's important for us to know them and to check them in the correct way. Talking about involuntary movements, well, I hope it gets okay. We must know that there are many kinds of involuntary movements, but the most important ones are tremors, myoclonus, tics, tardive dyskinesias, atetosis. You can see how it's moving, right? So we have here a concept of what we are looking for while doing the neurological evaluation. And we have to get the difference between spasms and twitches. Okay, any volunteer for reading this? Maybe, can you do it, Ruth?
Yes.
Yes.
Expanse, muscle expanse is a long contraction resulting in chronic pain. The switch is muscle switch is a short contraction resulting in middle pain and can be seen below the skin. The expanse contractions, long and persistent, and switch are short and mild. the pain spans are greater in comparison to a switch, and the switch is the pain relatively less.
Okay, thank you so much, Ruth. So having these differences done, we can understand that these involuntary movements are, of course, a cause of disturbances with our patients. And they come telling us that they really need to improve it, need to get the correct diagnosis, okay? And this is our first case report that I could start writing down, okay? Ariana, can you read this chart, please?
Yes. On examination, her face showed little or no expression. There was a tremor affecting mainly her right hand. She had generally increased muscle tone. Power, reflexes, coordination, and sensation were within normal limits. Examination of her gait showed that she was slow to start walking and had difficulty stopping and turning.
Thank you, Ariana. Thank you so much. So checking this box, we have so many expressions, so many ways of showing our ideas into case report as we were talking yesterday in the workshop. Using, of course, medical terminology, okay? If we can imagine how this patient or relatives are explaining the situation, it could be a very interesting dialogue for getting all the symptoms worked on. And of course, having this idea of this case report and the previous slides, we can talk now about the motor loss. The motor loss is a very common situation that every day is taking a big place into our evaluations. We have the symptoms and signs as the most common are including the weakness, the loss of power, the paralysis, complete loss of power. We can see this guy without moving and having trouble with half of the body. The tremor, involuntary rhythmic movement, especially of the hands. Sorry for my typewriting, I'm gonna improve it. And the abnormal gait, unusual manner of walking. Of course, we have lots of ways, lots of gaits, abnormal gaits that we could consider for a correct diagnosis or maybe a sign of a huge situation. As a general view, I can show you these ones, okay? For example, the speech may also be affected with hoarseness, a rugged voice as in vocal cord paralysis, or slurred speech means poor articulation as in a cerebral disease. And we have the symptoms of a fascia. Their fascia is supporting these two signs that we are looking for in our patients. The symptoms are trouble speaking clearly, trouble understanding speech, trouble writing clearly, trouble understanding written words, trouble remembering words, trouble remembering objects, names. All of these situations are very usual to find in elderly people. So, and we have to get the idea that we must get the difference of it. We have as an information chart the lesions in the primary motor, secondary motor, or premotor neuron, and showing the differences, specifically in the Parkinson's disease. Why Parkinson's disease? Because it's the most common situation where we can find motor loss, thought loss, speech loss, and everything that is now talked in this presentation. Any volunteer who would like to read it? I don't know, someone who could try to get a moment of this. Maybe Agar, can you do it, please? Agar.
I'm here.
Okay, go ahead.
Can you hear me?
Yes.
Okay.
Everything okay.
Okay. everything? You have to read it?
Yeah,
Or,
you can read
okay.
the two first lines. That's less for information. So, but we have here lots of vocabulary that we might remember for writing down the case reports, okay?
Okay, primary motor tremor is presented in the first signs of PD. Bradykinesia, slow movement indicating reduction of spontaneous movement.
Rigidity.
Inflexibility in the extremities, neck, and trunk. Postural instability, a tendency to be unstable when placed vertically.
Yes.
Secondary motors. The freezing of gait, important signal of the PD that he does not explain by the rigidity of bradykinesia.
Yeah.
Micrograph contraction of the patient's fist. Lack of facial expression, festivity, uncontrollable acceleration in the march. Premotor, loss of the sense of smell, constipation, sleep disorder, mood disorder, low blood pressure when standing, orthostatic hypotension.
Okay, thank you so much. Have you ever seen a patient with a Parkinson's disease in a deep or very advanced situation, I mean? When you treat a patient with this situation, with all of these symptoms and signs, taking into account the primary motor, secondary motor, and premotor disorders, the neurological system, of course, it's a very difficult situation to evaluate because they are non-cooperative. They don't do any effort for giving information or anything like that because they are without expressions. They cannot talk, they cannot move by their own, they lose the equilibrium. The rigidity and inflexibility in the extremities is very marked. I mean, it's not easy to get the correct evaluation of tone, of strength, and the positions. Even it's not easy to evaluate reflexes. So the postural instability is an important point of view because sometimes we receive patients that we consider is dementia, but now it's Parkinson's. And what's the difference? Of course, the tremor, the involuntary tremor all the time, then we cannot control. And the patient, of course, gets into many other situations. Mood disorders in these patients are related so close with depression, anxiety, and that they feel guilty about this situation because they cannot do anything by their own. So it's not a comfortable way to work with them. And it gets easy to get in confusion with the relatives. And of course, it's not easy to give support to families. It's a very difficult situation. And of course, they also have sensory loss. But sensory loss in the general view, we can consider the hearing, the sight, sensation, and feeling, and balance. Of course, the five senses that we always are talking about. John Harold, can you read this chart, please?
Yes. Hearing function, hearing, loss, deafness, other symptom, buzzing or ringing in the ear, tinnitus. Function, sight, loss, blindness, other symptom, double vision, diplopia. Blurring, loss of the visual acuity, clarity of the vision, sensation, feeling, numbness, anesthesia, tingling or pins and needles, paresthesia, balance, unsteadiness, ataxia, dizziness, vertigo.
Yes. Note, there are no common words of loss or conditions relating to taste and smell. So, for example, we can get a patient that comes to our consultant and says, and with the business sound all the time. While doing our case report, we have to report it as a deafness, right? We must remember this medical terminology for writing down in the correct way. That was what we were saying yesterday, right? When we have taste loss, like in COVID, I mean, we can express the idea saying that this is the capability of having a huge taste, I mean, an intense sensation of salty, of I don't know, salty, of like citric tastes, but flavors, I mean. And it's not an easy fact to treat it, because sometimes patients could say that there's no changes when they finish the situation. In Parkinson, most patients says that they are without taste. Everything has the same flavor, without flavor. Imagine eating paper. You can taste paper. It's awful. That's the flavor they feel all the time. And with the smell, it's a similar situation. They could feel the feces smelling all the time, all the moment. And they say that it's uncomfortable because it's not a way for living. They say, I'm stacking, I feel feces all the time, then it's going from me to the other people. So resolve it, doctor, please help me in that way. And it's not possible to do it. So how we can deal with that situation, right? It's not easy to do it. Almost we have another chart talking about sensory loss, when we can consider the feeling in our skin completely, and the full body, I mean. We have the peripheral nerve, carpal tunnel syndrome. We know it. It's very common situation, the secretory handwriting lesions, the nerve root C6, and a reticulopathy caused by any other injury, lesions in the spinal cord that can explain the situation. Of course, with the dermatomas and myotomas, we can get an approach of the piece that is in that injury, I mean, for having these symptoms. And of course, while the evaluation, we can see it as a signs. A polyneuropathy as a consequence of any other diseases, for example, diabetic neuropathy. The brain stem injury, of course, we know how to evaluate it, and the thalamic or cerebral hemisphere injury. With all of this information, we can evaluate in a correct way our patients. And of course, having the correct expression ways. Now let's talk about the loss of consciousness. When we have expressions from patients describing the situation, they use many number of ways of doing it. For example, I passed out, I had a blackout, I fainted. These are ways that patients come to us and tell us the situation. So we can consider it as an important way of expression, right? Moreover, they could also say, I had a fit, I had a seizure, I had a convulsion. They can commonly confuse this terminology with this other one. Of course, fit, seizure, and convulsion are related to violent involuntary movements, as in epilepsy. But as a doctors, we can get the differences, and while our questions, asking moments, we can get the difference about what is going on. And we can say, when did you lose consciousness? What's the situation specifically? Anything that is giving this situation, something that is, I don't know, symptoms that are telling your body that something is going to happen. We have to be creative, as I was telling in the first presentation. We have to find the correct way of asking for. but noticing the differences and how is expressed by patients these specifically terms. I passed out, of course, is the synonym of blackout and faint. And these ones are, as I was telling you, very, very usually confused for using, considering that they are no doctors. Let me see if there's Joyce. We have here this report is from a medical book, and it's just for information. I mean, it's gonna be helpful, okay? Maybe John Harold, can you read this box, please?
Yes. The principal differential diagnosis is between an epileptic fit and a syncopal attack or fainting. Syncope is a sudden loss of consciousness due to temporary failure of the cerebral circulation. Syncope is distinguished from a seizure
Whichever occurs.
The event occurs, for example, standing under a situation of severe stress or an association with an arrhythmia. Sometimes a convulsion and urinary incontinence, loss of control of the bladder, occur even in a syncopal attack. Thus, neither of these is specific for an epileptic attack. The key is to establish the presence or absence of prodromal symptoms, or symptoms that occur immediately before the attack. Syncopal episodes are usually preceded by symptoms of dizziness and lightheadedness. In epilepsy, people might get a warning known as an aura that an attack is going to happen. Note the non-convulsion is often used in plural form. He had convulsions as a child.
Yeah. Okay, perfect. So we understand all of these meanings, right? I mean, the lightheadednesses, of course, that bulb lights in our visual field that only we can see, and that's showing us that we are going to faint. It's an important situation. Or maybe dizziness with most of the people that suffer a syncopal or epileptic attack. They said, as I was quiet and suddenly I feel dizziness and then the lights and then a headache and then I don't remember anything. These prodromal symptoms are showing us that patients can get that period variable in time for losing consciousness. And that's important for us to teach them that when it happens, they can take a security position, for example, or can look for help, or can lay down on the floor in the left side for protecting the airway, right? That's why they get a warning and then have to know the aura. The aura is showing this situation. And of course, during the attack, during the aura and the post-attack, they have the incontinence of the sphincters, not just the urinary one, okay? So they can get vomiting, they can get with the stools, they can get urinary incontinence. And it's the situation for making guilty the patient, they cannot control it. So it's important. We have now this chart with pictures showing the situations that is helping us for understanding and practicing our expressions in English, okay? The background, sudden loss of consciousness caused by certain triggers. Result of a temporary decrease in blood flow supply in the brain, a prodrome usually associated with trigger event. The triggering event is that situation that can start the event. For example, in epileptic patients, could be the fast changes in lights. I mean, like in the movie theater, for example, they cannot go and relax watching a movie because these changes of images and light so fast can trigger the epileptic attack. So that's not a good idea to go there, or maybe to to a concert in a theater, it's not a good idea to go there because the lights are so fast, and the brain gets so stimulated in some areas. And this is a point of start the situation. These triggering events are important for patients to identify. And of course, doctors, we have to help them to find them. Sometimes they don't feel the prodromes, just the attack happens in a sudden way, but it's not a very common situation. And the prodromes, most common ones: dizziness, lightheaded, fitness, sense of being warm or cold, the pallor, this is the most common, the pallor, nausea, the sweating is very common, the sweating, palpitations, the blurry vision, the hearing changes. So it's important for us to remember it. And now we have the causes of syncope. The syncope has a different situations that are not always related with just the neurological sphere, okay? We have cardiac situation, orthostatic situation, neurocardiogenic situation that of course we have to consider, seizures, the neuropathic, the other ones, mechanical and glucose, the cerebrovascular. Glucose is one of the most important that not always we consider it as a point of view that we could check on it on this time. So now taking it in account, we can continue. The syncope is a very, very important way of the differential diagnosis, okay? And usually we can find patients that are in coma. That coma is the situation where we know patients sometimes are not able to come back to us. I mean, it's unconsciousness with reduced response to external stimuli. The way of expression that we use is the patient is in a coma or the patient is comatose. Both of them are correct. Both of them are the most common ways of expressing in this patient, okay? And of course, it's a bad joke, a black joke about it. But we have here an interesting vocabulary. The readings look good. Readings are the studies that are connected to the patient, monitors, I mean, when we can see the pulse rate, heart rate, breathing rates, these are the readings from the monitor ones, okay? Readings look good, but just in case, when was the last time the system was checked for bugs? For bugs, I mean, confusion systems, of course, it's a skeleton man. These readings are of course failing, okay? Of course, the Glasgow Coma Scale. Maria Fernanda, can you read this chart, please?
Eye opening, spontaneous, to sound, to pressure, none. Verbal response, or orientated, confused, words, sounds, none. Motor response, obey commands, localizing, normal flexion, abnormal flexion, extension, and none. Glasgow Coma Scale score, mild, 13 to 15, moderate, 9 to 12, and severe, 3 to 8.
Thank you so much. So of course, for us as doctors, it's an obligation to know it by memorizing. But we have to remember the correct vocabulary of expressing it, right? It's just for remembering, and it's a helpful picture, I think. And well, with this chart, I'm showing the coma data criteria, trauma coma. This criteria is showing us how to get into a classification of the patients, just for information, and maybe having more vocabulary for reading. For example, the category 2, the second category, cisterns are present with mild line shift, 0 to 5 millimeters, and or lesions density with a volume not exceeding the 25 milliliters. So this for imaging comparisons, but we have here few vocabulary for checking it, just as an information chart. We have this picture that is showing us the normal consciousness, how is the brain working on, which structure is working on in that moment. And we can to take into consideration that when we get in the locked-in syndrome, how the structures are loss of function in the vegetative state too. Just the destruction of the cortex and hemispheres, intact ascending reticular activating substance. There is no problem in these structures. And the brainstem death, irremediable damage of the brainstem. There is no way of solving it. Yeah. Again, an information chart. And then we have the pathologies of the nervous system. There are a lot of ones. A volunteer who would like to read this first chart. Maybe Johan, can you do it, please?
Okay, just give me a second.
Yes, is that okay with your connection? Okay,
Miss, I
maybe
can
connection
give
is
it.
better. Okay, don't worry, Johan, I'm going to take it in count. Mario, can you read it, please?
Yes.
Okay, go ahead, please.
We have the head and meninges.
Yeah.
Myalgia, headache, migraine headache, cluster headaches, encephalocele,
Encephalocele.
meningocele, hydrocephalus, meningioma, and meningitis.
Wait. Meningioma.
Meningioma.
And meningitis.
Meningitis. Disorders of the brain, mild cognitive impairment, dementia, severe dementia, vascular dementia, encephalitis, Reye's syndrome, tetanus.
Rice syndrome. Rice syndrome, yeah.
Okay. Rice syndrome, tetanus, Tourette syndrome.
Yes.
Neurodegenerative disease, Alzheimer's disease, Parkinson's disease, and Huntington's disease.
Yes.
We have brain injuries, amnesia, concussion, cerebral contusion, cranial hematoma,
yes.
Epidural, subdural, and hematoma. Traumatic brain injury, we have cope, cope, and counter blow. Shaken base syndrome. And we have levels of consciousness. We have conscious, unconscious, lethargy, stupor, syncope, coma, persistent vegetative state, and delirium.
Yes, thank you so much, Mario. About the cope, is this a term that explains when we have an accident, for example, we have a contra cope, for example, we crash a car and we go to the front of the car and our head goes to the glass. This specific place receives the contra cope. It's the brain, it's the skull, and the lesion is in this place you receive the hit, I mean. The counter blow is, for example, in the shaken baby syndrome. When you have the accident, you receive the hit in the front, but the lesion is in the occipital region. I mean, it's in the other side as a line situation, I mean. Or for example, you receive a hit in the left part of the cranial bulb of the cranium, and the lesion is in the right side. Is that okay? Is this possible to understand? Explaining it but this way, because it's not a very common situation to get it into an explanation.
Yes, it's okay.
Okay, sorry, it's the shaken baby syndrome. I'm going to correct it before sending to you. Any other volunteer, please, for reading the second chart? maybe, I don't know, Ariana, can you read it, please?
Yes. Brain tumors. Malignant brain tumor. Benign brain tumor. Intracranial pressure. Pinched nerves. Radiculitis. Cervical radiculopathy. Lumbar radiculopathy. Multiple sclerosis.
Demyelination.
Demyelination. The strokes, ischemic stroke, transient ischemic attack, aphasia, hemorrhagic stroke,
Aphasia, yeah.
arterious venous malformation, and cerebral palsy. Sleep disorders, insomnia, narcolepsy, sleep deprivation, somnambulism, epilepsy and seizures like tonic-clonic seizures and absence seizures. Spinal cord, myelitis, myellosis, poliomyelitis, post-poliomyelitis syndrome, spinal cord injuries, abnormal sensations, causalgia, hyperesthesia, paresthesia, peripheral neuropathy, nerves, amyotrophic lateral sclerosis, Bell's palsy, Guillain-Barré syndrome, neuritis, sciatica, and trigeminal neuralgia.
Okay, thank you so much, Ariana. And have you ever seen the restless leg syndrome? In Spanish, el síndrome de las piernas inquietas. It sounds very funny, but it's a very painful situation with the patient. It consists in a myoclonus movement constantly and or in many cases permanently, and the patients can't stop shaking legs all the time. And of course, during the time and passing the hours through the day, it can get harder and painful. And sometimes it can be controlled using calcium, intravenous calcium in the fluids. Many other situations are not possible to solve because it's a lesion in the spinal cord, even with surgery. And if we try to correct it, of course, patients are going to lose the possibility of gait. Very hard situation to treat. But now we have our chart of abbreviations related to the nervous system. Of course, just few of them, not all of them, because it's too much information for just a picture. But these ones are very important that we are going to use in the next model, of course, and practicing. One situation that it's perfectly treated by a neurologist or even a psychiatrist is the attention deficit hyperactive disorder, ADHD. Very common situation, non-attended situation, but we have to understand this. This is not a disability, it's a condition. Or the obsessive compulsive disorder. This disorder is very common in our career, I mean, but well, we have to understand this kind of people. And the transient ischemic attack, I think we all have a patient with this situation. I mean, very common one in elderly people, right? So using these abbreviations, we are going to start writing down, okay? Try to use them. Well, when we talk about the nervous system, it's of course a huge topic, very, very lot of information, a lot of readings that are in depth of this, but we have to continue talking about the mental illness. We talked about the structure, now we talk about the function. Mental illness, well, the most common ones are depression, the panic disorder, the schizophrenia, the post-traumatic stress disorder, bipolar disorder, dementia, and phobias. As a general side, these 7 situations can respond to the behavioral disorders in general, right? And in general, the signs of mental illness are these 6 ones. This is the one of the, it's a complete complete chart I could find. The appetite or sleep changes, extreme mood swings, chronic low-grade depression, hallucination, unhealthy coping mechanisms, unusual emotional outbursts. Yeah, can you see them? All of them related with the mental illness that it's not easy to talk about it. The patients that recognize that it's a situation in the mental sphere would consider they are running crazy. And of course, they are not going to look for help as the first sight. It's a long process to check, to accept, right? And there's a long process, the treatment. It's not for this, take this pill and everything is going well. That's not the way it's working on. Of course, we have the psychiatric disorders that we can consider as a big deal as a general practitioner, recognizing and of course we're working with them. Agar, can you read this slide, please? Agar? Well, maybe she's not there at this moment.
Yes, I'm here.
Okay. Okay, can you read this slide, please?
Psychiatric disorders can be divided into organic and functional. Dementia is a mental disorder due to organic brain disease. The commonest form of dementia is that associated with old age, senile dementia, disorder in which there is no obvious pathology or anatomical change in an organ are termed functional.
Okay, thank you. Thank you so much, Agar. So go ahead to the picture, maybe. There are just symptoms for understanding. Well, dementia, an umbrella term used to describe a set of symptoms that can include changes in memory, perception, reasoning, attention, concentration, thinking, judgment, and language, right? And this is an important part, the organic and the functional differences for choosing which one is going to be the principal doctor treating the situation, right? Going to psychiatric disorders and neurological disorders. This difference is showing us that we have a huge ways for the psychiatrist treating these situations, the Tourette syndrome, the ADHD, anorexia, their anxiety disorder, schizophrenia, obsessive compulsive disease, and lots of them. They are strictly linked with the personality type, early life cognition, and the habits that the patient has after these situations specifically. The neurological disorders, of course, are supported by the function that could be studied into the genetics spheres, yeah, by making the genetic map, the genetic code for each patient. We can consider the migraine, epilepsy, strokes, multiple sclerosis, Parkinson's disease, Alzheimer's disease, and migraine and personality type and early life cognition. Let's slow down, okay? So we have to consider these differences for knowing that some of them are genetical disorders that have that possibility of being transmitted generation to generation. Some of them could be acquired or maybe could be passed into our families. For example, schizophrenia is a very common situation that could be misunderstood, but we know that it has a genetic way of appearing. One of the most important studies talking about schizophrenia shows a complete family. I don't remember the name of the last name of the family, but it's an iconic case because there was a couple, mom and dad, of course, that had 12 children. 6 of them have schizophrenia, and the other 6 are without schizophrenia. And all, of course, when parents, while during the growing time, school time, were noticing the situations of the 6 schizophrenic children, they were treating the 6 ones without the schizophrenia, like investigating if they could develop the situation. And making this comparison, we can find the points and the ages that are the most common stages for getting the correct diagnosis. I mean, around the 15 to 17 ages could be a big point of view that is checked into this family. But of course, every family situation is different. The ones that were without schizophrenia had the stress trauma situation that they could develop this illness, this disorder, and at any time, because that was the conclusion that psychiatrists did, but it wasn't a correct diagnosis. They were without the situation all the life, but they were used to live with that fear, I mean, without a normal life, because they were always in controls and checkings and comparison situations, trying to find if they could develop this situation. And the schizophrenic ones, of course, had treatments that were starting from home and then going into institutions for treating this. So it's a very, very huge way of treating, okay? Of course, we also have the Alzheimer's and the Lewy body dementia, these 2 kinds of dementia that are not the same look as if they were the same, but of course they are not. And with Alzheimer, women have higher chance of developing. The median survival age is 84.6 years old, caused by amyloid plaques and neurofibrillary tangles in the brain, and most common time of dementia. But to get the correct diagnosis of Alzheimer, we need a biopsy to get documented that we formed the amyloid plaques. If there is not an amyloid plaque, we cannot give us a topic view that it was Alzheimer's. That's why the diagnosis is done in post-mortem, not while the patient is alive. We can infer the Alzheimer is the situation is happening because of the symptoms and the situations are happening and the progression of the situation, right? The Lewy body dementia, men are at higher risk. The median survival age is 79 years old, second most common type of dementia, and caused by buildup of Lewy body proteins in the brain. This one can be studied and taken by biopsy while being living. There's a huge differences. Alzheimer's diagnosis is in postmortem. Lewy body dementia could be diagnosed while being alive. Of course, both of them have a similar treatment, but the end of the situation is little different. Well, talking about substance abuse, it's a very, very huge topic. So we are going to make the principal ideas just. Okay, Ruth, can you read this slide, please?
Yes. Abuse of a substance means using it in a way that is harmful. The commonest form of substance abuse are alcoholism and drug abuse.
Thank you so much, Ruth. So I know, I think we all know someone who had these problems maybe, or maybe as med students, we get the information and maybe patients with these situations, right? But in general, even if it's alcoholism or drug abuse, we find behavioral changes, the signs of addiction that of course patient is not going to accept as a first moment, of course. The secretive behavior, inflexibility with plans, lying about plans, financial troubles, stealing money or substances, isolating, disregard for others, gets alone easily. And if you see all of these pictures, we could find even colleagues that are in these situations. We have the anonymous alcoholics, right? We have the addiction, anonymous addiction groups of supporting this situation, right? For example, anesthetists, in an easy way can get into this kind of addictions because of drug abuse during the research and studies. In the hospital I was working, the last one, we had a terrible situation where a colleague, an anesthetist, go into suicide by an overdose. We as a group were so surprised because while talking between us and trying to understand the situation, we found most of these troubles with these signs, but we couldn't see all of them. We couldn't accept that there was a huge problem, and we couldn't do something for helping her. So it's not a taboo. It's not something that we can lose, and we can complete consider that it's out of our reality, right? Of course, we have here more symptoms. For example, drastic changes in weight. We have trouble with the law or with the authority, violent outbursts, excessive sleepiness could be, or insomnia on the other hand, withdrawal from friends and activities. There you go, they prefer to stay alone. So it's important for us to check it and to recognize the symptoms and the signs and try to be there for that person. We also have the affective disorders. That's very important for us to recognize too. Catherine, can you read please this first column, please?
Teacher, affect and mood are similar in meaning and refer to the emotion, for example, happiness or sadness. Affect tends to be used for temporary emotion and is expressed through manner of speaking, facial expression, on behavior.
Yeah.
Mood is used to refer to a more permanent emotional state, the most common for of affective disorder.
Disorder
is depression, the symptoms of which are poor appetite, or significant weight loss, sleep disturbance, for example, insomnia, inability to sleep, fatigue, loss of energy.
Thank you so much. So we can see this. Fabiola, can you read the second column, please? Fabiola.
Can you hear me?
Yes, thank you so much. We are listening to you.
Some psychomotor agitation. for psychomotor retardation,
Mhm.
loss of interest
Flow in stimulating activities.
Okay. A decreased ability to think and concentrate, feeling that one is of no value to others or that one has done something wrong, recurrent thoughts of death or suicide, 5 or possibly 4 of the above symptoms occurring nearly every day for at least 2 weeks constitute a major depression.
Thank you so much, Fabiola. So we can see that affective disorders are a very common situation too. As we have the addiction signs and substance abuses, we can consider these ones that are related to each other. They can go ahead by hand by hand. And of course, it's a very deep and a very complicated situation to solve and to treat, but we must recognize them, okay? In general, the types of mood disorders are the bipolar disorder, seasonal affective disorder. If it's a rainy day, I'm going to get extremely sad. If it's a sunny day, I'm going to be happy. Or maybe in the opposite side. For example, it's a sunny day, I'm depressed. But it is so strange. The chronic depressive disorder, the major depression, of course, anxiety disorder, psychotic depression, postpartum depression. The postpartum depression, it's a very, very difficult situation. And it, of course, in our society, it is not taken into account as a big problem because they said, you're a mother, you can do it. And of course, no, it's not an easy fact, right? So we have the neurotic and stress-related disorders. We have to consider these situations for having a great idea of what's going on. Belkin, can you read it, please?
Yes.
Okay, please go ahead.
Neurotic and stress-related disorders. An example of neurotic disorder is obsessive-compulsive disorder. An obsession is an idea that is so persistent that interferes with the patient's life. A compulsion is an obsessive idea that forces the patient to act even though they recognize that isn't necessary. A common form of this compulsive washing of the hands stress is a feeling of being unable to cope. It can lead to anxiety or fear of problems. A sudden attack of anxiety is called panic attack.
Thank you, Belkin. Anxiety.
Anxiety, sorry.
Yes, thank you so much. So we can see that the neurotic and stress is not an easy way because it's a very common situation, but we can recognize it. We can work on it. And of course, we have symptoms of neurosis, and the most common signs of neurosis are shown here. Mario, can you read them, please? Mario. Hi, Mario.
Yes, sir.
Okay, please. Can you read all these charts, please?
Okay. The left one says symptoms of neurosis. Thought and confession, egoistic disturbance, self-consciousness, anger, anxiety, and irritation, feeling of guilt and hostility, fatigue and depression, and emotional instability.
Yes, perfect.
And the right one says common signs of neurosis: conflict caused by lack of emotional resilience, codependent, making it known they are stressed to others, constant need for validation of reassurance on any matter or issue, being a perfectionist, losing control of emotions in a serious conversation.
Yes, thank you so much, Mario. So you see, these symptoms are treatable. And of course, we have acute stress disorder symptoms, more symptoms that we are studying. And the post-traumatic stress disorder, the diagnosis criteria. For example, maybe John Harold, can you read this slide, please? Harold.
Yes.
I'm sorry. Let me get back. Okay, go ahead, please.
Acute stress disorder symptoms. Intrusive, involuntary, and distressing memories, dissociative, feeling dazed or slowing of time, negative mood, inability to feel positive emotions, avoidance, stressing clear of people, steering clear of people, places and situations to avoid memories, arousal, intensify startle response.
Yeah.
There are two.
Yes, please, the second one too. Post-traumatic
PTSD
stress disorder.
diagnostic criteria.
Yeah.
Negative alteration in mood, intuition, avoidance, stressor, alteration in arousal or reactivity, duration, functional significance, and exclusion.
Okay, thank you so much. So we are gaining more symptoms, more criteria, more vocabulary for this time of studies. And of course, we have other types of functional disorders. These include behavioral syndromes associated with psychological disturbances, such as eating disorders. Anorexia could be one of the most important ones, one of the most common. And of course, we have potential signs of eating disorders: excessive exercise, preoccupation with feeling fat, abnormal electrolyte levels, intense fear for gaining weight, unusually large intake food, anxiety around or avoidance of eating, very common in teenagers, very common situation. And we have disorders of adult personality and behavior. For example, personality disorders, of course. We have the Disney princesses because all of them have a specific situation. For example, Mulan just wants validation without considering her real situation, without considering the risk she was taking, right? Rapunzel, of course, has a situation that is very, very difficult to understand because she was kidnapped. She was enclosed into her tower, and when she wanted to go out, she felt guilty about doing something by herself without the green light of the mother, right? Tiana, our lovely princess that is obsessed of working, she has a obsessive compulsive disorder. Ariel left herself for complaining, for having a relationship with someone who really didn't know. That's a very, very difficult situation. Of course, they are cute, they are nice, they help us to understand that everything could be love, but there is not a normal way of learning, and we have to be so clear about these situations. Bella has the syndrome of Stockholm. She fell in love with the one who was capturing her. Of course, it's not a normal situation. Jasmine fall in love or was obsessed with the one who was lying here all the time. No, we have to take in account that these examples are just a little bit for trying to identify these situations. I'm sorry if I break a little bit of our childhood, but it's important for us to know that kind of situations that's very common, very usual, very in our societies are very are normalized, I mean. And of course, we have the mental retardation related to the mental development, okay? Could be by an organ organ failure, could be acquired, could be wild a congenital situation, or it could be as a consequence of a traumatic brain accident or something different, okay? And we have the schizophrenia, another disorders which are the delusions, the false beliefs. The symptoms of schizophrenia in general are delusions, hallucinations, disorganized speeches. The negative sphere of schizophrenia in Mini-Hats, it's like a room with two different walls, two different ways of acting, and it depends on the triggering triggering situations that shows us the moment that it's happening. The negative sphere, flattened affected, reduced speech, lack of initiative, right? We have a patient with both sides completely different ways of acting. And of course, children have the same situation that we can consider in a period of time for studying. With delusions, flat affect, bizarre behavior, hallucinations, paucity in speech and thought, disorganized thinking. With these specific 6 points of view, we can consider the problem. Now, well, we finished the mental sphere way of talking, and we have to get into another topic that, of course, it's completely different. We are going to talk about blood, but blood in a general view, because it's a too large topic one. We have to consider the full blood count, the FBC, which is the simple test and investigations of blood diseases, or many kinds of diseases that we are studying for. Ariana, can you read this slide, please?
Yes, the full blood count, the simple test in the investigations of blood diseases. And FBC measures the following in a sample of blood: the amount of hemoglobin, the number of the different cells, like red blood cells, erythrocytes, white blood cells, leukocytes, platelets, like thrombocytes, the volume of the cells, the erythrocyte sedimentation rate, the ESR, measurement of how quick red blood cells fall to the bottom of a sample of blood.
Thank you so much. The sample of blood is the quantity we take into the syringe. That's all. We have this anatomical review again, the blood composition, for getting in mind the correct way of writing down every name of every kind of cell, just for remembering. And we have a very common situation, the anemia, that is written down in the USA form with anemia, like in Spanish, and the United Kingdom written form, anemia. Both of them have the same pronunciation, anemia, and that's all, okay? That's the most common disease of the blood. It may be due to bleeding, loss of blood, excessive destruction of red cells, or the low production. The diet is lacking of or is deficient in iron. The most common situations, of course. And we have this dialogue when we have to consider again the vocabulary, okay? Maybe 2 volunteers for reading, one the professor and the other the student.
Can I?
Okay, Belkin, you could be the professor. Who would like to be the student?
Me.
Okay, Maria, go ahead, you both, please.
Okay. Am I the professor?
Yes, you Belkin are the professor.
Okay. What's the most likely diagnosis in this case?
Most probably carcinoma of the bowel with chronic blood loss.
What's again that's as a diagnosis?
Well, he hasn't had any change in his bowel habit or lost weight.
What else would you do included in the differential diagnosis of severe anemia in a man of this age? In a man of this age, sorry.
He might have leukemia of some sort or aplastic anemia, but that's rare. It would be very unusual. Another cause is iron deficiency, but he seems to have an adequate diet.
Okay, now, there is another cause of anemia which I think is more likely.
Chronic bleeding ulcer?
Yes, that's right. But what about the pernicious anemia? Can you exclude that?
Well, he's got none of the typical neurological symptoms like paresthesia.
Okay, thank you so much, you couple. That's a great job. So we have here this discussion with the case, okay? And that's the way we can express, of course, with the correct vocabulary, as we were talking on the course. But now, well, the topic that we are talking is about the pernicious anemia, because it has a great vocabulary for studying. These are some language notes that are taken by a student. So we can get into reading. Ruth, can you read it, please?
Yes, pernicious anemia is a condition in which there is atrophy of the gastric mucosa with consequent failure of intrinsic factor production of vitamin B12, malabsorption. The onset is insidious with progressively increasing symptoms of anemia. Patients are sometimes said to have a lemon yellow color owing to combination of pallor and milk jaundice caused by excessive breakdown of hemoglobin because of ineffective red cells production in the bone marrow. A red sore tongue, glossitis, is sometimes present. Patient present with symmetrical paresthesia in the fingers and toes, early loss of vibration sense, weakness, and ataxia, and sleeping may be palpable.
Yes, thank you so much, Ruth. So we can see lots of vocabulary that it's well used during the case report, right? So this is a way of expression that is going to help us to understand how we must write down from this point, okay? Johan, are you there? Can you listen to me? Maybe he continues with.
Yes, I can hear you.
Hey, thank you, Johan. Can you read the second column, please, for understanding a little bit the vocabulary that is expressed in the first column? Johan.
Second.
Yes, this one, the meanings.
Onset, beginning, insidious, slow developing, color, lack of colors, mild, slight, jaundice, bilirubin, breakdown, division into smaller parts, bone marrow, soft tissue in the cavity of bones, symmetrical, each side the same, vibration sense, ability to feel vibrations, progressive, continue to develop. Palpable, can be felt with the hand.
Thank you so much, Johan. So you can see this is the meanings, and there we have expressions that patients can use for expressing their doubts or their symptoms. And here, the verb reduce has several meanings in medicine. For example, to make a smaller, I mean, with better reduce the dose of your tablets. In surgery, reduce is to return on an anatomical position. Hernia can normally be reduced by manipulation, or in chemistry, to remove oxygen or add hydrogen nitric. I see this reducing agent, right? So we have to take in context what we are talking about for getting the correct meaning of reduce. And now we have the last topic, the oncology. I mean, it's a huge topic, a very, very common situation and difficult to treat, to understand, and to have the correct, it's not an easy fact to talk about it again. We have the concept of neoplasms. Catherine, can you read this slide, please?
Okay, teacher. Neoplasm, abnormal new growth of tissues.
Tissue.
Tissue. Okay.
Yeah.
Malignant neoplasms, cancer are likely to spread and cause serious likely to spread and cause serious or death.
Yeah.
Begin neoplasms do not spread.
Yeah, the benign plasm.
Beginning neoplasms do not spread
and are less harmful, right?
Are less harmful.
And are less
when speaking to
harmful.
patient, Dr. General said, growth or tumor.
The tumor, growth of tumor.
Growth of tumor. You have a small growth of tumor in the bowel.
Okay, thank you so much. We know that bowel is the synonym of intestine, so that's okay. And let's go ahead. Agar, can you read this slide, please?
A lump or swelling is a collection of tissue or fluid which is visible or palpable. Can be palpated or felt with the fingers. A lump may be due to a neoplasm, but there are other causes such as an inflammation or fluid accumulation.
Yeah.
Patient says, I have a lump in my left breast. Doctor says there was a firm, palpable mass in the liver.
Perfect. This is a lump.
Lump. Okay.
Yes. Thank you so much. So we have this girl asking herself, what does a cancerous breast lump feel like? And we have hard to touch, feebly surface, commonly located in the upper outer quadrant of the breast, does not move during a breast self-exam, and it can give us an irregular shape, right? With these symptoms that, of course, while during evaluations get into signs, we can get the idea. And we also have a palatine lump. It's a very common new situation that we are usually watching now in the new consultations, right? So we have these differences, the malignant tumors. And Fabiola, can you read this slide, please?
Okay.
Hey, thank you so much.
Malignant tumors are characterized by rapid growth and invasiveness. The tumor may invade local tissues or may spread to distant parts of the body. Metastases. Neoplasms, which are the result of metastases, are called secondaries, as opposed to the original tumor, which is the primary. We have
Yes.
results of the scan. Sorry?
No, continue. Go ahead, please.
Okay. We have the results of the scan back now, and I'm afraid they show that you have a small growth in the prostate. Fortunately, it appears to be at an early stage and there is no sign of spread. So if we remove it, there is every chance of a complete cure. Note, to invade is to enter and spread throughout a part of the body, and this process is invasion. If a tumor is described as invasive, it has the ability to spread.
Okay, thank you so much. So we can check in here the vocabulary, right? Invade, local tissues or may spread to the distant parts of the body, the metastasis, that is a very important topic to talk about, right? And we must consider that this situation is common, but of course, our patients still think that when we say cancer, they are going to die without any treatment. And of course, it's not going to happen. Well, we have these pictures for having a correct idea for the benign tumor, cells that are not cancerous and won't spread. And the difference with a malignant tumor, the cells are cancerous and can spread to other tissues and organs. We know the differences as doctors, right? And the malignant neoplasm, taking the epithelium, the lamina propria, and the benign tumor that it's constellated, it's encapsulated, right? The cancerous tumor, the carcinoma, it's not in a very concrete place, I mean. What happened? Okay, let's go ahead. Give me a second, please. Okay. We have the symptoms and signs of malignancy. Maybe Johan, can you read this slide, please? Johan, can you listen to me? Let me see if he's still in class. Hey, yes, please read this slide, please.
Symptoms and signs of malignancy. The symptoms of disease may be related to the size and location of the tumor. For example, a space occupying lesion in the brain causes raised intracranial pressure and symptoms such as headache, vomiting, or visual disturbance. Tumors of the colon may block the lumen and cause change in bowel habit. Other possible symptoms of malignancy include bleeding, pain, and weight loss.
Perfect. Can you read the picture too, please? Johan? Okay. Well, let's go ahead. The common sites of symptoms and of cancer metastasis in a general way to view is the brain with headache, seizures, and vertigo, the respiratory system, cough, hemoptysis, and dyspnea, the lymph nodes, lymphadenopathy, liver, hepatomegaly, jaundice, and the skeletal system, pain, fractures, spinal cord compression syndrome. And of course, we know these situations are very common while talking about cancer metastasis in the very huge situations, for example, ovarian cancer or maybe liver cancer. Now we have signs of brain cancer, of course, for checking and increasing our vocabulary, the frequent difficulty speaking, trouble hearing, blurred or double visions, memory loss, confusion, changes in mental behavior, personality, loss of balance, weakness in arms and legs, and seizures, right? Very common situations, very common ways of consider this. And the colon cancer, of course, has its own symptoms and signs. Bowel habits changes, maroon colored or black stools, rectal bleeding, abdominal discomfort, bowel doesn't empty completely, usually in elderly people, abdomen fullness feeling, usually in young people, fatigue, weight loss. As you see, most of the situations have the weight loss as a common symptom, right? And where is my pointer? And we must consider, of course, the lung cancer and the breast cancer, very common situations, just an information picture for reading. But we have to know that these ones are not usual to watch. Maybe in our families with relatives, we got these hard situations to treat and control. And as a doctors, we cannot be without the assistance of patients. And we have this case. Any volunteer for reading it? Anyone who would like to do it? We are almost finishing, I promise. Okay, please go ahead.
A 33-year-old man presented to his general practitioner complaining of painless lump on the right side of his neck, which had been present for about 2 months and was enlarging. He had been feeling generally unwell and had lost about 5 kilograms in weight. He was also complaining of night sweats, and he had no significant past medical history.
Thank you so much. So with this case report, we have the way that we are expressing, right? And we have to consider the male breast cancer as a new situation that is going on actually, right? And sometimes we say that because it's a man, there's no breast cancer for him. Oh no, that's a mistake. If you have a nipple, you have the possibility of have breast cancer. That's the idea for understanding the situation. This chart is for information topic, I mean. And we have the risk factors. Male breast cancer is a rare cancer type and only compromises 1% of all of the breast cancers. Of course, it's not a common situation, but it doesn't mean that it's not going to happen. The male breast cancer staging, reflecting degree of tumor spread, is identical to female breast cancer too. So, right, you can see the difference. So there's no way for misunderstanding this or for losing a patient with this situation. And in a general view, we have the treatment of tumors. Any volunteer for reading, or if there is no one, there's no problem. Anyone who would like to do it?
I can read it.
Okay, Ruth, thank you. Go ahead.
The tumor can sometimes be completely removed or excised by surgery. If this is not possible, for example, if it has already metastasized to other part of the body, it be made possible to destroy it by radiotherapy or by chemotherapy. When a cure is not possible, palliative treatment is given, which is only intent to relieve symptoms.
Yes, thank you. So we have as a cancer treatment options, hormone therapy, surgery, bone marrow transplantation, chemotherapy, target therapy, radiation therapy, immunotherapy, right? And well, it depends on the stages we were checking now, remembering these difficult situations. And don't forget this, slow down, keep calm, be positive, take it easy, unplug, enjoy life, have fun, breathe, relax, go outside and meditate. If we practice these activities, maybe we can prevent these situations for us, and we can prevent many mental illnesses, mental situations, or maybe we can prevent the trigger points of these difficult diseases and illness to treat on. So that's all. Yes, yeah. We're almost finishing. Yes, yeah. So in that order, I'd like to ask you, my dear people, how you are doing with the homework I sent on Sunday. Is enough time to send me it on Friday night, or do you need more time? I don't want to stressful you.
I will need more time.
Yes, me too.
Okay.
Maybe the Sunday.
If we get more than the half of the group needing more time, we can get more time until Sunday night, I mean. 2 days more. Because I know there's a lot
Yes,
of
could be better.
work and a lot of job to do, and of course we have activities. Okay.
I'm also gonna need more time.
Okay. I know, for example, Maria, you are in tests and evaluations this week. And well, I understand the situation. It's not easy. It's not easy to do it. And well, I have to consider it and not getting complication with you, right? Right. I'm going to write down to the group and for everybody to get the idea. Okay. So getting in accordance, let's fill the diary pool for assistance. Can you watch this? Yes, please fill the diary pool. Okay, 9 to 9. Someone left. Okay, I think everything's okay. And well, that's all. So as we said everything, let me correct little details in typewriting in the presentation. I'm gonna send it to the group, and don't forget the homework is gonna have more time for making it until Sunday night, and that's all. Okay, so see you tomorrow in the workshop, and please try to check the slides for solving doubts or prepare questions for the other presentations. That's okay for me, and let's work tomorrow. Bye bye, everybody.
Thank you. Bye.
Thank you. See you tomorrow. Bye.
Bye. See you. Bye. Bye. Hi, John Harold.
Hello, teacher. Is it okay if we just have the meeting tomorrow like we used to?
Yes, could be tomorrow, but maybe tomorrow we don't have enough time for talking about your case report, maybe. It depends on you. There's no problem for me.
Yeah, because the class was a little bit long.
Yes, it was so long, too many topics to talk about, and I know it's not easy. I'm sorry for taking the time.
No, it's okay, teacher.
Okay, so there is no problem, John Harold, so that's okay for me. Did you check the guidelines
Thank you, teacher. See you tomorrow.
for making the case report? Did you check
Yeah,
the guidelines?
the guidelines
I sent it to you.
Yes.
Yes,
I
it's
saw
just
it.
for you, please. I'm sending these guidelines for the ones who made homework, because I have 8 reports from 14 students. The guidelines to everybody, right? So please don't share it. I'm doing it in personal, but to everybody. And please, I'm asking for not to share the information in this opportunity.
How much time do we have to present the new reports?
The report as soon as possible.
Do we need to
There's
send it
no
like?
problem.
Okay.
If you can correct it tomorrow, maybe that's okay for me. There is no problem. Now, I was checking, you sent me the correct homework, the homework of the second week.
Yeah, I said you the homework was that was due for
Okay,
Friday,
that's
right?
perfect, Johan.
I just
Yes, at the beginning I said that, but yesterday most of all of your classmates asked me for more time. And I said that that was okay, but of course you have a plus with this. You have extra points for sending in on time. Thank you so much. I really appreciate this.
Okay, teacher.
Okay.
Then see you tomorrow.
Yes, that's okay for me. So go and take a deep breath, relax, because I know it's a very, very long presentation. I'm sorry.
Yeah, don't worry, teacher. You too. Have a nice night.
Thank
Bye-bye.
you so much. Have a nice night too. Bye. Okay, we are almost finishing. I'd like to ask a classmate to get into again for filling the pool, because I don't think it's okay to leave him away, because he was working all the class and I know he has connection disturbances. I'm talking about Johan. Let me ask him by WhatsApp if he can get into and fill the pool. Can you get into the into the Zoom session? Fill the pool. Is that one more time? Yes. For your assistant, please. Well, let's expect his answer. I hope he can do it. I would like to, because he was working all the class. And I don't consider that it would be fair to go out and not to mark his assistance. Well, I'm taking in account the participation, of course, as I was telling them at the beginning of the course. And I have the proof that they are working now. So there is no problem. I know that it's a long session, but there are lots of topics to talk about and to recognize and to get in touch, and lots of vocabulary for studying and learning and practicing. But well, well, let's wait 1 minute more. If there is no answer, I'm gonna close it. In that order, that's okay for now. The poll is done. I don't know why people say that. There's so understanding of the context of today. But that's okay. There's no problem for me. And if there are questions tomorrow, I'm going to get them. Okay, let's give him some minutes. During this, I'm going to start correcting my slides. I have serious problems by typing, but I know I must improve it. Let's go with some music, just to 1 minute more, and that's all. No answering. Okay, maybe he can. Johan, please get into again and fill the pool. It's not fair. I don't want too much as an assistance. Hi, Johan.
Hello, miss. I'm just here.
Yes, I'm glad you could come back. Can you see the pool, or may I send it again?
No.
Okay, let me send it again, relaunch it, because you were working here all the class, so it's not fair to mark without assistance because of this diary pool. Thank you for coming back. Okay, thank you. That's great. Yes, thanks for coming back. Yes, it's done. Now let's go home and relax. I'm glad you could get into again. And well, see you tomorrow with all of the questions you could have about it, okay? I was talking to your classmates, and the second week homework, the 2 pages assignments and quizzes, as a common idea, agree, we get that you can send it to me until Sunday night, please. Or Saturday, you can send it to me earlier because for extra points, for extra scores, okay?
Okay, the last homework, right?
Yes, the last one, the second week homework, the quizzes and the assignments. I know
And the
it's a
other
lot
one
of job.
is when we can send it, right? As soon as
Yes,
possible.
the paragraph correction as soon as possible. Then the case
Oh.
report.
Okay,
You were so close to the idea, only just details to add, and that's perfect to me. And the assignments and quizzes in the Word file. So Sunday night is perfect.
Nice. Thank you.
Yes. Okay, thank you for coming, Ben Johan. So let's go now for having relaxing time.
Yeah, good night. Bye-bye.
Bye-bye. Yes, my student came back. Now everything is in order. So have a nice night and see you tomorrow with the workshop.